Endometriosis is a disease where the endometrial lining of the uterus grows inside the abdomen.
Endometrial cells respond to hormones, so they are the same cells that grow and shed when someone has their menstrual cycle or their period.
When you have that tissue growing where it's not supposed to, and essentially menstruating every month in the abdomen, internal bleeding every month, it causes a lot of pain and it can lead to infertility. Because the pain is predominantly in the pelvis, and because most of these lesions grow in the pelvis, we've always thought of this as an isolated gynecologic disease. But largely because of some of the research we've done here at Yale, we're identifying that this disease has impacts throughout the body.
For example, women can have concomitant cardiovascular conditions with endometriosis, neurologic conditions such as migraine, immunologic and autoimmune conditions such as fibromyalgia or chronic fatigue syndrome, which is indirect evidence that it's the disease that is not confined to pelvis but rather affects entire body.
I always had painful periods. I always had debilitating cramps and bad headaches. And that started when I was 13. Once I was 14, I started having really severe abdominal pain, and I was in the emergency room once every 2 weeks.
The gold standard diagnosis historically for endometriosis has been a surgical diagnosis, meaning we don't have great ways to diagnose it. Otherwise, 85% of patients with endometriosis don't have lesions large enough to be seen on imaging. Many people will have a diagnostic surgery to take a look inside the abdomen. This is done with laparoscopy, which means small incisions looking into the abdomen. We can bring a camera and really zoom in and see all of the tissue and look closely at it to find any potential lesions of endometriosis, to resect it and get a pathologic diagnosis.
Once it's diagnosed in a patient, I tell them we have good news and bad news. So the good news, we know why you've had this much pain throughout your menstrual cycles and so on. The bad news is that endometriosis is chronic, and basically a patient needs treatment for the entire length of reproductive lifespan.
Typically treat endometriosis first medically. Often something as simple as a birth control pill can stop endometriosis from progressing. We have other drugs that modify hormones. However, when hormonal therapies don't work, we often need to perform surgery.
The resection of those lesions and the benefit in terms of pain is variable. So it's not well predicted to say a patient will have this much duration of time with pain relief after excision, but we do know that when you pair surgical excision with medication management, specifically hormonal management after the surgery, you have longer durations of pain relief compared to surgery alone. So it's a tool, it is not curative.
After we found the right medication or regimen, what changed in your life? How did your life change?
Everything changed. I gained my life back because I didn't have a life. I was curled up in a ball in bed with a heating pad. I had rashes from my stomach because of how much I was using it. I was taking so many pain meds every single day. I had a pain management specialist. My entire life revolved around the appointments that I was going to. And now I'm working, I'm in school, I got my life back.
I am a firm believer that endometriosis has to be diagnosed early in life, not when a woman is in her 30s and planning pregnancy, but perhaps 14, 16, and so on, when she is experiencing those painful periods.
Several years ago, we identified microRNAs in the blood as very sensitive and specific biomarkers of endometriosis. We've looked more recently at using these same type of biomarkers in adolescents and younger women when the disease first starts.
We are not just diagnosing patients and providing clinical care. In this institution, we are doing cutting-edge research on non-invasive biomarkers for endometriosis, such as blood samples or saliva samples, with hope and goal to have a blood test that can diagnose a patient with reliable certainty of endometriosis without need to be doing laparoscopy.
We're also developing biomarkers that might help us choose the best treatment for somebody with endometriosis. The birth control pill is the most commonly used first-line medication, but it doesn't always work. We've recently published a paper that shows that we can identify who's resistant to progesterone, who's not going to respond to a birth control pill, so we can use personalized medicine to find the best treatment for each patient. This is an inflammatory disease. We're starting to understand the biology behind it, and I believe that will lead to new, more specific treatments.